I will now continue with the second half of my presentation. And for the rest of the presentation, we're going to focus on viral hepatitis, because this is where the most excitement is in the field of liver disease right now. So this cartoon to me really captures what's going on. And of course, it's a couple of people looking at a cost curve for healthcare expenditure saying, whoa, what happened there? And the response is that the baby boomers' livers cleaned us out. And I think maybe 5 or 10 years down the road, we may feel that way. I'm going to start with hepatitis B. And I'm going to then move to hepatitis E. And we're going to try and answer the same question for both diseases, which is how much hepatitis B and how much hepatitis E is there in the North American population? To help us answer these questions, we're going to look at a couple of posters from ACG. This is poster 833. And this is hepatitis B serology in the US population based on the NHANES study, which we've already talked about, from 2003 to 2012. This study, in this part of this NHANES study, they were able to collect blood from nearly 40,000 individuals and tested that blood for Hep B surface antigen, anti-Hep B surface antibody, and anti-Hep B core antibody. And what they found was about 0.3% of the US population was chronically infected with hepatitis B, meaning they were surface antigen positive, and 28.6% had only anti-HBs, meaning that they were immunized or vaccinated for hepatitis B. So the hepatitis B surface antigen positivity or actively infected population in the US is low, but the immunized population is probably not as high as we would like it to be. So some strides need to be made. I think the data in Canada may look relatively similar, although in some urban centers, Toronto, Vancouver, Montreal, where you have lots of immigrants from endemic countries for hepatitis B, these numbers would obviously be higher. A more interesting question in my mind is how much hepatitis E is there in North America? We don't think about hepatitis E a lot, but I'll remind you that it's a virus that's transmitted through fecal-oral transmission. It's typically associated with outbreaks, contaminated water supply, for example, in underdeveloped countries. And we also think about it in the context of pregnancy because when it infects a pregnant woman, it has actually quite a high case fatality rate. So we've never really thought that there's a lot of hepatitis E in North America. And the question is, are we right or are we wrong? So this is poster 1464 from ACG. And this looked at hepatitis E seropositivity in the United States from NHANES between 2009 and 2012. And in this study, they had blood from about 15,000 individuals throughout the US who they tested for the hepatitis E virus antibodies, both the IgG, which would indicate previous exposure, and the IgM, which would indicate recent exposure. And amazingly, they found that 6% of the US population was positive for anti-hepatitis E antibodies, and 1% was positive for the IgM antibody, indicating recent exposure. So I think that this really tells us that hepatitis E is prevalent, it's more common than we thought, and recent infections, even in a population that has not traveled outside of North America, is something to consider. So how does this translate into clinical practice? If you have an individual in your practice who has unexplained acute hepatitis, then I think hepatitis E is something to test for. Very rarely, especially in the immunocompromised or older population, hepatitis E can cause a chronic hepatitis, sometimes mistaken for autoimmune hepatitis, for example. And in those individuals, hepatitis E serology also would be helpful. In Canada, we can order these tests. They all go to their national laboratory in Winnipeg to be run. But we do have access to the Hep E IgG antibody, and if you request it, the IgM as well. So I would encourage you to think about this in your practice because it's more common than we think. So I will now move on to talking about hepatitis C treatment, where really there has been huge advances in the field and a lot of excitement about what's going on. I will take a little bit of presenter's privilege and move away from ACG and UEGW just for a couple of moments to highlight the fact that there were 2 new treatment regimens that should be on the market in Canada by the end of 2014, beyond what we saw in 2013. The first of these regimens was actually already approved by Health Canada on October 15th of this year, and that is sofosbuvir and ledipasvir for the treatment of genotype 1 chronic hepatitis C. The graph I'm presenting here is a summary of all of the clinical trial data in the phase 3 program. And as you can see from the patient profiles, we have treatment naive, treatment experienced, cirrhotic, and non-cirrhotic patients in these studies. And importantly, in the treatment experienced group, we actually have individuals, about 230 of them, that have failed protease inhibitor-based treatment. All of the success rates after treatment for all of these groups are over 94 or 95%. And in the entire program, you have an SVR of 97% amongst 1,952 patients. This is a dramatic improvement, yet again, over what we have had on the market to date. And given that this drug is a single tablet regimen, I think it represents an important advance for our patients. And hopefully we'll get our hands on it soon to use. I also am going to point out that we should be seeing by the end of this year, I hope, a new treatment regimen also for genotype 1 patients called the 3DR regimen. This is a 5-drug combination with some pills that are taken once a day and some pills that are taken twice a day, that also covers similar patient profiles, treatment naive, treatment experienced, genotype 1 patients that are both cirrhotic and non-cirrhotic. The difference here is that because this regimen includes a protease inhibitor, it will not be licensed for individuals who have failed previous protease inhibitor-based therapy. Nonetheless, you see again that we have very high SVRs across the board. And this will definitely also be a very appropriate treatment regimen for our patients. As we move to this era where SVR rates for hepatitis C treatment are all over 95%, and treatment regimens are a few tablets or a single tablet and getting shorter and shorter from 12 weeks to 8 weeks, maybe 4 or 6 weeks in the future, everyone has raised questions, I think, about how important adherence to treatment regimens will be. How important is it that every patient takes every single dose of their medication? What happens should they miss medication? When you're talking about a treatment regimen that may be $130,000, you definitely don't want it to fail because people aren't taking their pills. So this issue is just starting to be explored. And I'm going to highlight a poster here from UEGW, poster number 48. This was the adherence to prescribed doses of the 3D plus R regimen. And this was a data crunch from 2 of the phase 3 clinical trials. Now, what they did identify was that within these clinical trials, which is a very controlled setting and very well-selected patient population, adherence to treatment, every single drug, was over 98.5%. Virologic failure was not correlated with adherence. Interestingly, 5 patients that they could identify had adherence rates of less than 80% to 1 or more of the 5 drugs. This, despite less than 80% adherence, it actually had no impact on SVR12. So this is starting to give us a bit of comfort that a patient who misses a few pills here and there may not have a huge impact on their predicted success. However, I think it's going to be really important to see what happens in real life. And the question to me in real life is, does duration of therapy matter or do number of pills matter more? We've seen some recent data from a co-infection meeting that patients are likely to take every single pill early on in therapy for Hep C, but as therapy continues, they start to drop off. So how this translates to the masses as we start to treat individuals remains to be seen. But it's something to emphasize with all of our patients. So I'd like to finish with a summary and just highlight the fact that just like gastroenterology, there are huge advances in hepatology, assessment and treatment. We actually have a much better understanding of chronic liver diseases, their causes, and how we could possibly improve them to improve the liver health of the population. And many outstanding issues remain, and I think we have to stay tuned to future research and future meetings and future webinars, potentially, to learn more. Thanks for your attention.